Okay, yeah, we're right on time. Welcome, ladies and gentlemen, to the March edition of the PGSSC Research Seminar on Multi-Country Collaboration in Global Surgery. Today, we would explore two crucial topics: the CHITA protocol for routine sterile glove and instrument change during abdominal wound closure to prevent surgical site infection, and the use of azithromycin to prevent sepsis or death in women planning a vaginal birth. Our distinguished speakers, Professor Alan Tita and Dr. Antonio Ramos de la Medina, are pioneers in their respective fields, offering insights into these innovative approaches that have the potential to revolutionize surgical practices and involve and improve patient outcomes globally. The CHITA protocol aims to reduce surgical site infections, while azithromycin use presents a promising strategy to prevent maternal sepsis and mortality, particularly in resource-limited settings. Their expertise exemplifies the transformative power of collaboration in advancing surgical care. In our virtual setting, I would like to just take a moment to highlight some Zoom seminar etiquettes to ensure a smooth and interactive session. Firstly, please ensure your microphones are muted during the presentations to minimize background noise. Secondly, utilize the chat function for any technical assistance or logistical queries. Finally, I encourage you to actively engage with our speakers using the raise hand feature or typing your questions in the chat during the dedicated discussion period and Q&A sessions. Each presenter will have 25 minutes each for their presentations, and this will be followed by a 30-minute discussion sessions. I encourage you to make the most of this opportunity to learn, share, and engage. Next slide. Okay, so the PGSSC Research Seminar is an engaging 8-session series exploring the methods and outcomes of global surgery research. And the seminar aims to not only expand knowledge, but also to facilitate collaboration in advancing the field of global surgery. Each session usually features 2 speakers who share insights into similar methodologies or topics, which fosters, helps in fostering a robust discussion on the implications of their results. We believe that this approach is, very unique in the sense that it encourages a holistic understanding of global surgery research. And of course, it prompts, a very robust discussion afterwards from, our very, very eager participants. We have all these sessions recorded for broader disseminations. And of course, you can check our website for further information. Next slide, please. In our PGSSC Research Seminar Series, the coordinating team comprises of faculty's lead, Drs. Adeline Boateng and Drs. Bethany Head-Gauthier, alongside the PGSSC Fellow, my humble self, Marine, Afra, and Taylor. Together, we bring diverse perspectives and expertise to guide these sessions. For additional details, please do check our website to get updated. Before we proceed with the presentation, there is a Menti link that will be dropped in the chat. Please kindly click on it and let us know where you're signing in from. We would love to, know where everyone is calling in from. Thank you. Next slide, please. Okay, so without further ado, I would introduce our very first speaker. He's Dr. Antonio Ramos de la Medina. He's an active gastrointestinal surgeon and chief medical officer at Hospital Español de Veracruz, located in Veracruz, Mexico. He received his general surgery training at the National Institute of Medical Sciences and Nutrition in Mexico City, and did a fellowship in advanced gastrointestinal surgery at Mayo Clinic, Rochester. He's also the hub director of the NIHR Global Health Research Unit on Global Surgery Mexico Hub, which is one in 7 hubs around the world that works along with the NIHR, University of Birmingham, and University of Edinburgh to improve access and quality of surgical care around the world through collaborative research. He has led several research projects within the hub, which has coordinated more than 70 collaborating hospitals all over Mexico. He has also published multiple articles and book chapters on gastrointestinal surgery and oncology, and his publications have been cited over 8,000 times in the medical literature. What an impressive resume. Dr. Ramos, the floor is yours.
Thank you, Kate, and thank you all for this opportunity. I would like to especially thank Bethany for the invitation, and it's a real pleasure to be able to talk to you today about some of our research. I will go ahead and share my screen.
Okay.
Thank you for that kind introduction. And as Kate was saying, I'm Chief Executive Officer in Hospital Español in Veracruz, Mexico, and I do continue to practice gastrointestinal surgery. We'll go ahead and present the results of our CHEETAH trial. CHEETAH was our cluster randomized trial of sterile gloves and instrument change before closing the wound to reduce surgical site infections. Before we present the trial, I'd like to have just a few words about our collaboration. Our collaboration started almost 10 years ago. It dates back to 2014, when we conducted our first large cohort study. And we are especially interested in such type of studies, large cohort studies that set the basis for large pragmatic trials aimed at improving the delivery of surgery, especially in low and middle income countries. And we also are interested in practice-changing research. This, as presented in the introduction, we do have 7 hubs, 7 research centers around the world, and the places where the centers are can be seen here. These are the directors of such hubs. We have hubs in Ghana, Benin, Rwanda, India, Nigeria, South Africa, and the one that I have the pleasure to lead in Mexico. Those were the researchers that conducted the trials in different countries, but CHEETAH was the brainchild of Professor Anil Bangu from University of Birmingham, and under the leadership of Professor Dion Morton. But such a large trial, such complex trials as the one that we're going to be presented today, usually require a team. And this team is encompassed by many, many people. These are just UK team faces. These are from University of Birmingham and University of Edinburgh. And each hub has a team just like this one. This is the team in Mexico. And these are the people that really carry the burden of conducting these large trials. So I couldn't have done any of the things that we have done without my team. This is a true collaboration. So let's talk about a little background regarding why we conducted this trial. There are no recommendations by WHO regarding the change of gloves when it comes to closing the wound. So even not only not from WHO, there are no recommendations from CDC or the National Institute of Clinical Excellence. And there is strong evidence. I mean, this intervention is biologically possible. I mean, we do believe that this could work. We thought this could work beforehand. There were some previous trials which indicated a signal of benefit on meta-analysis, but the quality of the evidence was low and the risk of bias high, both of which limited the generalizability of the intervention. There were also cost and logistical implications, especially for countries like ours, low and middle income countries. So we thought that this was a trial worth conducting in order to find if this pragmatic intervention could be of benefit. So the study was designed as a cluster randomized controlled trial. Each hospital had a target of about 200 consecutive patients. And we did this because the idea was that the consent was easy, that this had an interventional change, a behavioral change, and we would randomize hospitals, groups of hospitals, or specific theaters or theater sessions or teams rather than patients. So this is a PICO summary of the trial, which included adults and children undergoing abdominal surgery with an incision equal or greater than 5 centimeters and a prediction of clean contaminated, or dirty surgery. C-sections were excluded due to the high volume of this operation in many of our network hospitals. In some cases, this was over 95%. So we didn't want this to be a trial that was only relevant to C-section. We wanted this to be, the results to be relevant for a broad range of abdominal operations. So to put it clearly again, we didn't want this to be a C-section trial. The intervention was change of gloves and instruments prior to wound closure for the whole scrub team. The comparison was the routine practice of each practice in hospitals. So in other words, what surgical teams would normally do, and the outcome was surgical site infections at 30 days post-surgery, defined by CDC criteria. So these are the main results of our trial. So we were able to enroll a little over 13,000 patients, 13,301 patients across 81 hospitals in 7 different countries. So this is a big surgical trial. I must also say that this trial was conducted, as you will see a little further, during the pandemic. And the hospitals were located in these 7 countries, except UK, where our units or research hub units are located. This is our recruitment chart. As you can see, the graph shows that recruitment advanced throughout the trial rather smoothly. We outpaced our recruitment projections. And if you look closely at the dates, you can see that this big trial was, as I was mentioning, conducted during the COVID-19 pandemic, which was an independent challenge in and of itself. This slide shows the patient demographics. As you can see, the intervention and control groups are pretty much balanced. There are no significant difference among them. This is the ASA grade, and as you can see, they are fairly balanced. There's some minor difference between intervention and control groups. And also the indication of surgery, you can see that cancer operations accounted for 17% of cases, but most of cases were for benign indications and just a few for trauma. About half of patients had elective operations. We also checked for compliance with WHO checklist, pulse oximetry, prophylactic antibiotics, and also hair removal, since these are interventions that could in a way have an implication regarding post-operative infection, surgical site infection. About 2/3 of patients had an open midline incision, and about 1 in 5 patients were classified as having dirty surgery. That means heavily contaminated surgery. Regarding follow-up, we conducted the follow-up in different ways. Since our hubs are different among each other, and some patients come from really far, we needed to conduct 30-day follow-up. We tried to improve the way that we conducted this. So about 17% were followed in person at hospital, but most of our patients were followed by telephone. This was also important due to the the pandemic, and we have a separate trial that also verified that this follow-up method was useful and was helpful in trying to accomplish what we were trying to do. This is our primary outcome, and the trial showed us a significant reduction in surgical site infection at 30 days when gloves and instruments were changed. Imbalances are very common in cluster randomized trials. However, we analyzed the data in different ways to account for such imbalances, like missing data. And after this analysis, the findings remained robust. These were secondary outcomes. As you can see, there were no significant results when it came to both groups, when it came to secondary outcomes. We also conducted a cost-effective analysis to see if the intervention had an implication when it came to cost. And the intervention of changing gloves and instruments, it came out to be cost neutral. The main result of the trial is that the intervention show a robust benefit to routinely changing gloves and instruments wound closure, and we suggest that it should be implemented into surgical practice worldwide. This is our visual abstract. So pretty much we showed that routine change of gloves and instruments, it's associated with a 13% reduction in surgical site infection rates. I think this is an important finding, since this is an intervention that can be implemented everywhere. It's cost neutral and can benefit many patients around the world. So in other words, this finding translates in preventing 1 of every 8 surgical site infections by simply changing gloves and instruments at the end of an operation for the whole team. So in conclusion, we do believe that it was a rigorously conducted trial that showed a robust effect and was consistent in sensitivity analysis. There are some limitations to our study. We did not include C-section patients. There were there were some difference between superficial and deep wound infection. And we did not account for, or we did not study the carbon effect of having more gloves that do contaminate the environment and requiring a new piece of instruments, a clean and sterile piece of instruments, that carry a burden also on the environment. Regarding the next steps, we are delivering these presentations to talk about the importance of this, and we're trying to work together with several surgical associations around different countries and with WHO to propose for global implementation of the results. To end, I'd like to probably comment on someone that is very close to Harvard program in global surgery and social change, that is Paul Farmer, that says that with rare exceptions, some of the most important achievements on your time in the planet will come from working with others, in a word, partnerships. And this is what we're trying to do. We do believe in collaboration. We do believe in working together with as much people as we can to improve the results of surgery, to improve the access and delivery of surgery around the world. I'd like to thank you for your attention, and I'll be open to any questions and comments that you would like to address to me regarding our CHEETAH trial. Thank you.
Thank you very much, Dr. Ramos, for that insightful and provoking presentation. Indeed, behavioral change adopted by theater team is very low cost in comparison with, surgical site infections, which are, ordinarily expensive and, have wide-ranging effects on patients, families, and health systems. So thank you once again, Dr. Ramos. To our audience, I'm sure you have, interesting questions to ask him, but we'll just save that till we get to the discussion session. We would go on to the next presentation. So I'm delighted to introduce our next speaker. He's Professor Alan T. M. Tita, MD, PhD, Professor Tita is Mary Hensick's endowed chair and director at the Mary Hensick Institute of Global Health and the Hensick School of Medicine Associate Dean of Global and Women's Health at the University of Alabama, Birmingham, USA. As an OBGYN professor and senior vice chair for research and innovation, he has also led the university-wide Center for Women's Reproductive Health. His background is in maternal-fetal medicine, perinatal epidemiology, and global health. Professor Tita is dedicated to improving maternal and infant health outcomes. And he has led and continues to lead collaborative multi- and single-site obstetric perinatal clinical trials and observational studies that all influences practice and policy globally. He co-leads the Cameroonian Health Initiative, a multidisciplinary collaboration by University of Alabama, Birmingham, and Cameroon partners to improve healthcare. Professor Tita has served as consultant editor for obstetrics and gynecology and consultant for the World Health Organization, NIH, CDC, and the American Board of Obstetrics and Gynecology, Academics of Medicine, and to the Association of American Physicians. Professor Tita, the floor is yours.
Yeah, thank you so much, Kate. I really appreciate that introduction and want to go ahead and thank Dr. Boateng as well as your lead committee for this invitation. It's a pleasure to be here and to also hear Dr. Ramos Medina speak, and congratulations to you on your work. I see there is an intersection here in Birmingham and sort of an intersection of the world. Let me go ahead and share my slide and we'll get this going because I'm really looking forward to engaging with the group and having a great discussion. Let me get this right. All right, is that, Kate, does that look good?
Yes, it does.
All right, again, thank you so much. No specific relevant conflicts that I would like to declare. You know, as you may know, maternal and neonatal sepsis, or just sepsis as a whole, is top 3 cause of maternal and newborn death globally. It is increasing among the causes of maternal death, accounting for 10%, as well as it also accounts for approximately 16% of newborn deaths. And its prevention and treatment is of increased priority to international organizations, including the World Health Organization. So a couple of years ago in 2016, in a multi-center trial called CSOP, a single 500 milligram IV dose of azithromycin given to women undergoing a cesarean delivery in labor reduced maternal infections by 50%, as well as also reduced readmissions and unscheduled visits. The intervention was also reported in a separate study to be highly cost-saving and was subsequently endorsed by the American College of Obstetricians and Gynecologists in 2018 as the standard for prophylaxis in patients undergoing an unscheduled cesarean delivery. So the question arose, well, what about the majority of women who deliver vaginally, right? Is there an opportunity to reduce infections, which also occur in these patients and contribute to the mortality crisis? So in pilot trials in the Gambia and also by our group in Cameroon, oral doses of 1 to 2 grams of azithromycin versus placebo given to women in labor and planning a vaginal birth suggested reductions in the rates of maternal infections in both studies and neonatal infections in the Gambia study. So with that in mind, we set out to test the following 2 hypotheses in patients undergoing a vaginal birth in a larger, hopefully definitive trial. And the specific hypotheses were, 1, maternal that a single prophylactic dose of 2 grams of azithromycin given to patients in labor will reduce maternal death or sepsis. And that in neonates, for the second hypothesis, the same intervention would reduce intrapartum or neonatal death or sepsis. And just to go on with our methods here and a little bit of background, as you can see here, this was called the A+ trial, azithromycin prevention in labor use trial. This trial was conducted at 8 sites of the NICHD, that's an NIH institute, global institute, and which funds a global network in 7 countries, shown here in white. And the Indian side country, you can see Belagavi and Nagpur, there are 2 sites there. Each global network site is made up of a US team and a low and middle income country team collaborating to conduct studies in the LMIC setting. A data coordinating center is based here in the US at the RTI in North Research Triangle Institute in North Carolina. And there is also involvement of NIH scientific officers. NICHD or NIH provides the core funding for the network. And in the case of this A+ trial, the Bill and Melinda Gates Foundation provided supplemental funding. So this is how this network is set up. It's been around for now 20+ years, and really puts together a competitive process and validates perhaps years of ongoing work by these teams that then compete to be part of the global network. And so that's how we were able to be part of this, because we are one of the sites in the global network, with the PI here being Dr. Wally Carlo, who is a pediatrician neonatologist, and our primary site for UAB is in Zambia. So in the trial included were patients in labor in facilities who were 28 weeks or greater with a live fetus confirmed with a Doppler, and who were planning to deliver vaginally. And again, all had to provide informed consent. And there is indeed an elaborate process of IRB approvals through all the US institutions, through the data center, and then at each country having their national and other regulatory authorities evaluate these trials and approve them before study initiation in those countries. So excluded on the left panel were those with infections that would require antibiotics for treatment, those with known arrhythmia or cardiomyopathy, because there is a question of QT prolongation with azithromycin. Also, obviously, those with allergy to azithromycin or macrolides in general, or use of macrolide antibiotics within 3 days to prevent the effect of that antibiotic from affecting the outcome. And then finally, they were considered to be in advanced labor, in some places considered to be at least 10 centimeters dilated, in some places considered to be above 6 centimeters dilated. They were excluded. This is the intervention: azithromycin, 2 grams or placebo. We gave 500 milligram tablets, again, following a sequence that was computer generated in a random fashion and stratified by each site. At randomization, the next sequential pack was assigned or pulled, and the intake observed. So this really intervention was directly observed, and so ended up with a very high rate of adherence. This is a design summary of the A+ study. You can see, that for pregnant women in labor in these 8 sites in 7 countries, randomized to azithromycin or to placebo. And then importantly, shown there in orange, though usual care was allowed in both arms, including antibiotics that would typically be used for various reasons. Primary outcome, maternal death or sepsis for the first hypothesis, followed through 42 days or 6 weeks postpartum, and then intrapartum or neonatal death or sepsis for newborns followed through 28 days. Sepsis, maternal sepsis was defined following, recent definitions at the time from the World Health Organization, shown here, which warranted infection, either suspected or confirmed, and the additional presence of organ dysfunction. And so we operationalized this then as having a suspected or confirmed, usually obstetric or other infection. We require the presence of fever or hypothermia, as defined here, and 1 or more signs of organ dysfunction shown here. So, tachycardia, systolic less than 90, at 25 or more breaths per minute of tachypnea, altered mental status, jaundice, output, urinary output when measured, reduced, and very rarely the presence of renal failures if creatinine was obtained, and this was also very rare. So the definition was essentially clinical and therefore relatively easy to operationalize in LMIC settings. And these were some of the infections that would lead to suspicion of sepsis in combination with the other findings. So usual obstetric infections, really shown here, then pyelonephritis, pneumonia, or the presence of any other infection. For neonatal sepsis, this included proven or possible serious bacterial infection, pneumonia, or meningitis. The definition of a possible serious bacterial infection followed WHO criteria shown here, including fever or hypothermia. Laboratory findings were also considered for adjudication if present. And again, both outcomes were adjudicated on an ongoing basis. A couple of secondary outcomes, the components of the primary outcome, those maternal specific infections that I showed earlier on, and then also measures of healthcare resource use that we will talk about, and then any reported adverse events, including pyloric stenosis, which has sometimes been associated with prenatal with postnatal use of macrolides. So this is just to show some of the flow and how we had this done. Community sensitization very important prior to initiating any study. And then for this specific study, patients could be consented early on in pregnancy, so prior to coming in for delivery. And this depended on the site, but essentially it had to be, if that was done, reconfirmed at the time of admission for delivery. And then obviously ongoing screening processes, randomization, drug administration, following really closely for outcomes. And you can see towards the bottom there that we really paid attention to not missing infections, right? And putting things in place, including home visits, day 3, 7, and 42 to confirm infections, evaluate the patients, but then also having supplemental infection assessment visits based on phone calls, which Dr. Ramos and the team used as well, and can be very effective because you can determine whether there is a problem and then do additional things to validate that problem and determine whether it's an infection or not. So multiple encounters, and if a home visit could not be conducted, then some sites actually had them come in or if that could not happen, then the phone visit was sufficient. But it's really amazing that this vast majority of patients had these home visit encounters and follow-up. All right. Then these are just some other resources that we developed just to communicate with the patients and communicate with clinicians so that everyone was on the same page about maternal and neonatal sepsis and to increase the likelihood of suspicion and diagnosis. And so these were posted in various places in the facilities and also actually given to the patients to also have with them so that even if they went to another location, then the providers would pay attention to this and not miss infections. All right. The sample size was 34,000 going in, would provide over 90% power for effect sizes, lower approximately 0.75 to 0.8. So trying to detect even small differences. We estimated a baseline of maternal sepsis or death at about 3% upwards and newborn 8% upwards. At an interim analysis, at approximately 70% of the cohort enrolled, which was 70% of primary outcomes identified was the milestone for interim analysis, but that corresponded to 86% of the planned sample size enrolled. The Data Safety and Monitoring Committee recommended stopping the trial for maternal benefit, and NIH accepted that, and so here are the results, which were published sometime about a year ago, and this is what we found. So as you can see, similar to the Cheetah trial, this also occurred in the middle of the pandemic, and you can see this sample size was enrolled in about 2 years, which I just, I've been involved with different networks, and it's just amazing to see the global network do this and really navigate the challenges of the pandemic. During this period, that was when the pandemic really hit hard in India, and people were falling off in the streets, and one of the sites there in Nagpur in India was affected and had to shut down for a period of time. So, but in any case, out of the 44,000 screened, 29,000 plus randomized equally into azithromycin or placebo groups. And as you can see, greater than 99% had complete follow-up, and approximately the same amount actually had the medication taken. And then we had primary outcomes on them. Again, that just emphasizes the complete dose of 4, greater than 98% there. All right. So baseline characteristics are shown here, and very, very well balanced. You can see a majority, 55% came from the Asian countries, 43% primiparous, 18% down high, in bold at a labor induction. And just under 9% met criteria that we had predefined to meet what we would call high-risk status, defined as having been in labor for at least 18 hours or having had a membrane rupture for at least 8 hours prior to randomization. We also had an alternative diagnosis that was to meet these points or time points prior to delivery, which obviously will allow more to be called high risk. And during their labors, again, pretty well balanced, including cesarean delivery rates subsequently in 14%. Antibiotic use during and after labor was really high. There you can see approximately 50+% usual care use of antibiotics in this population. Huge discrepancy between the Asian sites where this was so high and the African sites where this was just minimal. And then also some additional data here in median time from randomization to delivery, and 13% meeting the criteria for high risk prior to delivery. And so let me just show a few results here. The primary outcome of maternal sepsis or death was reduced by approximately 33%, 2.4% to 1.6% in the azithromycin group shown here in red and in subsequent graphs. And then these are the components. You can therefore see maternal deaths, obviously rare, no differences there. And then, so this is really driven by sepsis with approximately a 35% reduction there. Several other maternal infections, endometritis, wound infections, whether after a cesarean or a perineal or a vaginal with a perineal, and any other infections, all reduced by 30 to 35%. We also looked at these resource use measures, including readmission within 42 days, rare but significantly reduced, as well as unscheduled visits for care, also similarly reduced. Regarding neonatal outcomes, no difference between groups here, so more consistent with the findings in Cameroon than in Gambia. Again, this is intrapartum neonatal death or sepsis, 10% or so per group. And not shown here is the neonatal, so this is the primary neonatal outcome. And then these are the components here where you can see neonatal deaths. Again, no difference. You can see neonatal sepsis, no difference, and not shown as stillbirths that accounted for 0.4% per group. Resource use measures, no difference as defined here for newborns. And then when we did subgroup analysis for the maternal outcome, we show here that the findings overall were consistent with the overall finding. And in orange there, you can see those were pre-specified subgroup analysis, and blue down below were some of the post hoc analysis we did. The main finding here is here. I hope you can see my pointer. It's right here where the effect or the beneficial effect of azithromycin appeared to be stronger in Africa, where there was less antibiotic use than in Asia. I would say that Dr. Carlo is doing additional studies and is looking at not just sepsis or death, but looking at the presence of any infection, which is how we approach the US trial. And regardless of continent, azithromycin for any infection appears to be lead to maternal benefits. So reported adverse events here, no difference really between groups, but we noted that the pyloric stenosis group had 8 in the azithromycin, as well as versus 3 in the placebo groups. Both groups lower than what one would expect for background rates. So I think, right, we've gone through, some of this, but lower outcome rates in Asia than we anticipated. High use of prophylactic antibiotics there, and for statisticians, when we did a power calculation, we did not account for the fact that we had 2 primary outcomes, but post hoc, clearly the findings, maternal findings, even adjusted for that, would still be highly significant. And then we also, I don't present those here, but we do have antimicrobial resistance studies going on in this population, and also microbiome studies that we are actively working on. I don't think the strengths can be overstated. I think those are clear. And I just want to briefly call attention to another study here that was done in the Gambia, a large trial that was done in the Gambia, as well as Burkina Faso. And overall, they found no differences in the primary outcome defined here as neonatal sepsis or death. And their sample size was much lower, 12,000, because they focused on neonatal sepsis or death. You can see 2% versus 1.9%, which is, again, much lower than we had in the A+ trial at 10% per group. But if you drill down and look at some of the secondary outcomes, I have some of the maternal sepsis findings there. You can see that those results are consistent with our findings when you take into account the fact that they have a much lower sample size, even though it's a huge sample size of 12,000. So in conclusion, we believe azithromycin prevents maternal sepsis or death. The number needed to treat is 125 to prevent 1. If you look at azithromycin and any infection, the number needed to treat, information that we are looking at is about 1 or 60 to 1. And it reduces use of health resources, no effect on newborn outcomes. And overall, these findings are consistent with other studies. So we do believe that more work should be done here to look at how this can be translated into policy in a responsible way. And we're going to do the microbiome and antimicrobial resistance studies to inform that process, as well as some of the others who are doing azithromycin studies and engaging with different organizations, including the World Health Organization. And so it takes a village to get something like this done. And this is just a very small part of the team. I was looking at Dr. Ramos's slides and thought, great, it would have been great to have some photos here, but I'm really very grateful to these authors and their teams shown here, as well as their larger teams for the A+ trial, as well as some of the ongoing ancillary studies related to the A+ trial. So thank you very much for your attention, and I'm happy to and really delighted to take any questions. Thank you.
Thank you very much, Professor Tita, for that insightful presentation, which has, provided us with valuable perspectives on how multi-country collaboration can enhance the implementation of an intervention that holds significant implications for maternal health worldwide. So we will just proceed with the next session, which is the discussion session. But before then, if you have not already filled the Menti poll, please kindly do so now. We would love to know where you're attending from. Okay, that aside, I would want to encourage all of you to engage actively with our speakers, by using the raise hand feature. Okay, you'll be called upon as you appear on my screen. Please kindly turn on your camera if your bandwidth permits, and briefly introduce yourself. We would love to know more about you, and you can then ask your questions subsequently. Please note that we would like to get everyone's views, so no question is too small or too big to be asked, and don't feel that the question should be asked only by people at certain stages of their career. So everybody's welcome to ask our speakers, our distinguished speakers, questions. So with moderator privileges, I'll go ahead and ask the first set of questions, and I'll start with Professor Tita. So Professor Tita, considering the diverse healthcare settings across participating countries from the multi-country study, how was standardization truly achieved in terms of the trial procedures and the primary and the secondary outcome assessments, to ensure that consistency and reliability of the data? It was such a huge study, and it becomes very difficult to really get things standardized to ensure that the results are something that we can generalize. So could you just throw more light on how standardization was truly achieved to get the results you got?
Yeah, no, thank you for a great question, and I think that was accomplished in a number of ways. And while acknowledging that there were certain things that we allowed to occur, according to usual care. In fact, most things we allowed to occur according to usual care. And the only difference was that one group got the placebo and the other group got the azithromycin. But when it came down to determining the outcomes, we really had an elaborate process, right? A clearly defined outcomes. you know, when what criteria for those outcomes, which I presented, when we would start detecting those outcomes, obviously post-randomization, but up until specific time points. And then a huge part of this elaborate process was ongoing training of the teams and encouraging just multiple. We had like every 2 weeks, teams were meeting, discussing findings, discussing approaches, and then we would have frequent training and retraining sessions. So everybody was on the same page about the criteria. And then the research team was supposed to go back and then interact with the clinicians to make sure that all the materials that we had produced to show how this would be defined were or suspected were actually in places visible to them and that they were following this. So we paid a lot of attention to that. The other thing that we did was, it was not clear to us that sites measured temperature, right? This temperature was a crucial part of defining our outcomes. So we provided guidelines on what thermometers to use. We even tested a number of thermometers, and then also provided guidelines on how frequently, a minimum frequency of measurement of temperatures while in the facility, and then also during those home visits. So all of these things, right, to sort of disparities to try to narrow.
Right.
That's what we did.
Okay, wow, that's very interesting. Dr. Ramos, relating this question to your own research, right? What strategies would you recommend for adapting and implementing behavioral interventions in different contexts, considering, you know, the variations in resources, infrastructure, and surgical practices? Dr. Ramos.
Well, that's definitely a challenge everywhere, especially since even though we are all from LMICs, it does pose as a challenge, not only between countries, but also intra-country, because hospitals are different from like rural settings to more urban settings. So we pretty much had 80 strategies to minimize and monitor biases. So one of the things that we had a minimum of 4 hospitals per country. That was one of our strategies. We had a pre-randomization identification of units regarding within clusters. So we said, is this going to be operating theaters, list, teams, or sessions that are going to be included in the cluster? We also try to minimize the randomization by country and hospital type. That was another thing that we also were very particularly interested in. We also had site training delivered after randomization of the different clusters. We also had a warm-up week to train teams regarding the intervention that we were going to do. We had a sticker that would have to be placed in the chart in order to register consecutive patient identification. And we also were monitoring characteristics of patients at the unit level. So pretty much those were many of the things that we tried to implement in order to, account for imbalances and biases.
Great response. So we'll just open the floor for people to ask questions now. And I can see the first hand here. Afra, would you like to unmute yourself and come on, open your video and introduce yourself briefly before asking your question?
Hi, everyone. My name is Afra. I'm not going to come on camera because my Wi-Fi is always terrible at the moment. But I currently work with the NIHR GSU, and also I'm a fellow at the PGSSC. And I wanted to maybe ask a question that is less specific to these sort of the clinical aspects of your work, but maybe these, you've done both of you have done really impressive studies that, require a lot of coordination between huge teams, huge like very diverse teams within varying variably resource context. And I was just wondering if you can maybe shed some light or give your insight and advice into like how you work in teams that are so big, that are so functional, and are able to produce such good output. Because surely there must have been hiccups along the way, I suspect. But so it'd be really nice to hear about your thoughts on that.
Thank you very much. Yeah. All right, I'm gonna thank you so much for that question, and I think it gets at the core of the success of networks like this. I'll just use my own experience. So I have been part of the Maternal Fetal Medicine Units Network, which is another NIH funded network for US studies alone. And so collaborating with Dr. Carlo here, we're able to go into the global network. And you see, and it's even a more complex network in the sense, right, that you have people of more disparate backgrounds, cultures, and everything, and you have to collaborate to bring these things together. I think it also helps that these are teams that, before they come into the network, had already had some period of collaboration to even be able to successfully compete for the network. So to your point, I think it's so crucial to come in with a collaborative disposition, understanding that everybody has something to contribute and brings a certain experience that may inform a question that may not be clear to you coming from another culture, but speaks at something that allows the program or the trial in this instance to be successful. So everyone in the global network has a very collaborative predisposition, listens to everything that people say, even sometimes when it's like, wow, why like it sounds like, even when it sounds crazy, there is something in there that allows us to, acknowledge that, talk about it, and make progress. So I think that's the primary, ingredient. Don't dismiss anything that someone brings up, but talk through it and be collaborative. Thank you. Dr. Ramos?
Thank you, Dr. Tita. I think that what Dr. Tita has said is it's key. I would probably add a couple of things. Dr. Tita conducted a trial that is rather similar to the one that we conducted. It was in 7 countries among different. It's a little bit bigger, like 3 times bigger, or at least double. So that's impressive. That's amazing, and congratulations. But I think the key is time. We've been working together as a network for 10 years. So we've developed this in prioritization workshops in which the voice of everyone is heard. We do conduct an horizontal hierarchy. So everybody's voice has value and input into what we're doing. So that's important to hear to everyone and have a true collaborative spirit. Of course, there needs to be leadership in place, just like a central, like Birmingham BCTU, the Birmingham Clinical Trials Unit works really well, and they have experience in such large trials in such different places. And the local leadership, it's really important, but it's finding the right people, finding the right mindset to collaborate. I again talk about the horizontal hierarchy. So there is this thing that it's called the Anna Karenina principle that comes from Tolstoy, that says that all unhappy families or happy families are different. Are the same, but all unhappy families are different in each way, or I'm probably saying it backwards and I just wrecked the quote. But what I'm trying to say is that a good trial, a successful trial, does require the same things all over the world, and it's collaboration and having your voice heard.
Thank you for that response. Okay, so we have another hands raised here. Reynadi?
Yes.
Yes. Thank you. Go ahead and ask your questions.
Thank you for the chance. Hello, everyone. My name is Renardi. I'm a general practitioner currently practicing in a rural part of my country, Indonesia. I would like to ask some questions about the research work by both Dr. Ramos and Dr. Tita. First, for Dr. Ramos, you mentioned before about the use of telephones as your primary means of following up patients. In your experience, how did you make sure that the data or that the answers given by the patients were accurate and valid and that they could be contacted in the first place? And also, I'm wondering, why did you specifically exclude for C-section among many types of surgery? And one more question to Dr. Tita. Does your research, can your research be applicable to other types of antibiotics? For example, in my country, many community health centers did not have azithromycin, but use other types of antibiotics as prophylaxis in vaginal birth. Thank you for the chance.
Thank you.
Thank you for the question. I think that's a very good and fair question. One of the things that we did is that it's like I was mentioning on the presentation, it's really complicated to conduct a follow-up in some of the countries that we work at. And this was especially important during the pandemic. So as part of the CHEETAH trial, we had a trial within a trial that it's the Talon 1 study. So what we did is that we adapted a wound healing, the wound healing questionnaire, universal reported outcome measure for using global surgery trials. And we conducted these interviews and we tried to understand whether this intervention was sensitive enough to detect the follow-up of patients that do develop a surgical site infection, which also it's important. We also thought about including photographies that could be sent to the unit in order to evaluate these. But and it posed a challenge because there are some it needed to be adapted cross-culturally, and also it needed to be translated into different questions. This telephone interview needed to be standardized so that we would all be asking the same questions. And so these separate, we had already conducted such a trial during our Falcon trial, which it's a different trial that we conducted a couple of years back, using chlorhexidine and compare it to iodine, povidone iodine in regarding to diminish surgical site infection. And so we already had some evidence that this would work, and we did find that the implementation of these interviews, it's significant, it's important, and it's a useful tool for this. Regarding how we excluded C-section, this was a pre-design. So we said these patients are going to be excluded. Otherwise, we would have had probably a C-section trial, and we wanted our results to be relevant to a broad, different abdominal operations. So it was a pre-specified exclusion, and the hospitals that would only conduct C-sections would be excluded, or the theaters, the operating rooms that would have C-sections would be excluded, and it was only for hospitals that would conduct 200 consecutive cases that were abdominal operations.
All right, so let me thank you so much for your question. I'll jump right in. I'll also just indicate that based on relatively, lower quality evidence here in our institution, we double gloves. So we changed the gloves for C-sections at the time of closure of the wound. And I've always questioned, why don't we do a bigger study to get at this? I'm sure there are other places that do not. I wonder what is done. Dr. Boatin and others there. But to your question here about using other antibiotics, I want to really emphasize that what we are reporting with azithromycin is regardless of the use of other antibiotics, okay? So let me step back and go to the previous, the US trial that, shaped practice here. 99% of those participants got a separate and additional antibiotic because they were undergoing a C-section delivery. And most often that was, in fact, vast majority, that was a cephalosporin. And the reason azithromycin was proposed in that setting was because in preceding studies, urea plasma organisms were identified as a frequent cause of post-cesarean infection. And these usual antibiotics, do not cover for urea plasma. So the question was, in addition to those things, can we have a greater impact? And we had a 50% reduction. Now, there are additional research questions as to whether flagyl, metronidazole, would have a similar effect or not. But I think those are the top two, azithromycin and flagyl would be the top two to be considered in terms of extending your prophylaxis. Now, to the setting, this case of anticipated planned vaginal delivery, even though some subsequently have a C-section, as I indicated, about 50%, 53% of this population had other usual care antibiotics, and most commonly these were penicillins and also cephalosporins and flagyl. And so the effect that we report here is in addition to that, broad use of antibiotics. So that use is so high in Asia, but not in Africa, that the question arises, can one then do a head-to-head study where you say, give the azithromycin and then, don't use all those other things that you use, usually for, situation of overuse. So could we reduce the level of antibiotic use by comparing azithromycin versus those other antibiotics and still see whether we have the same potential benefit? So I hope that helps. Thank you for your question.
Yeah, thank you very much for that elaborate explanation, Professor Tita. I was gonna sort of ask that, given our population of people already on, antibiotics, would that have, impacted on the results? But you have clearly, elaborated and explained that, there's actually a separate form of organism that leads to, these infections that happen, subsequently. So that explanation was very, very illuminating, and I'm sure our audience, benefited from that explanation. So I'll go next to Bethany. Bethany, go ahead, unmute yourself and ask your questions.
Thank you. I'm Bethany Heck-Gauthier. I'm Associate Professor of Global Health and Social Medicine and the Director of Research for the Program in Global Surgery and Social Change. Excellent presentations. Thank you for being here. I actually have my burning question is a bit of a follow-up to the questions that were just asked around antibiotic use. Dr. Tita, you talked a little bit about resistance in wanting to know more about resistance, and definitely in the sites where I support work, there's lots of questions about both interventions that might lead to resistance or the circulating resistance and how that might undermine interventions that we're exploring. So I would love for you to comment a little bit more about what you're thinking about in terms of how resistance would factor into your consideration of this. And then Dr. Ramos de la Medina, similarly, even though antibiotics weren't necessarily the core part of your study, just thinking about resistance testing available at the sites that you support, and how you're thinking about resistance, both in this study and in future studies, and how that might impact clinical care.
Yeah, I think, I'll jump right on, because that's the next question we get, probably the most important question that we need to address to potentially shape policy. And so going into this, we did design a number of studies to get at resistance, and those are being wrapped up, and we're working towards publications. The first study we did was just to look at, as part of this process, as much as we could, whenever an infection was identified, could we then also do some studies to determine the resistance pattern of those, in any organism, and especially the resistance to azithromycin. So sort of a clinical resistance thing from actual infections. Then we also did a serial surveillance of a subpopulation of this study, 1,000 or so plus, where we sampled them at baseline, 7 days, at 6 weeks, at 3, 6, and then 1 year. And that study is also in the process of wrapping up to see, just overall, without any infection per se, do the colonization by bacteria, do we see any change in the resistance patterns of those, and is there a change in those patterns over time? So we are going to be able to speak to that. And then the other thing of interest is microbiome, which we also sampled serially and are working through. That it remains to be analyzed with some complex studies that are really above my pay grade, and we have the right people working on them. So to come, just to address your question, that is so crucial that we are going to put out information. If I look back at the US trial, when we looked at resistance to just overall resistance and a resistance to azithromycin, the resistance rates of organisms from infections were actually lower in the azithromycin group. Were actually lower. In this study, I know that it wasn't higher there wasn't a higher azithromycin resistance, but we did see some level of background level at baseline of high azithromycin resistance in some of the settings, right, which would reflect a broad antibiotic use. But despite that background level of resistance, we did see a benefit of azithromycin, right? So what we are going to inform more is what happened to resistance patterns, and that will be out soon. But I would say from studies done in the Gambia, they saw from those serial surveillance as transient rise, modest rise in resistant organisms, and then a drop after the antibiotic was given. And again, these are just, I don't want to minimize them, but these are not in actual infections. These are just changes in the patterns of organisms on the flora. I hope that helps, and more to come as we talk about policy implications. Thank you.
Thank you very much, Professor Tita, for that elaborate explanation. Robert, you're next. You're muted. You're muted.
So maybe while we wait for Robert to come on, I was curious to hear Dr. Ramos de la Medina's comment on that as well.
Thank you, Bethany. Thank you, Bethany. We did not conduct antibiotic sensitivity or resistance analysis, neither in cheetah nor falcon. We had conducted previous to these two trials a cohort study regarding the frequency of infection in different countries. It was a much larger cohort study, and what we did find is that the use of antibiotics was of prophylactic antibiotics was high in low and middle income countries, and it's counterintuitive, but also the resistance to such antibiotics were higher in low income countries, in middle income countries, than in high income countries in that order. So the places where they were having more infections and they were inappropriately using antibiotics had the higher resistance to them. So that was a prior knowledge that we had, but we did not specifically look for this at the cheetah trial.
Yeah, if you don't mind, I'll just chime in to totally agree with that. It's similar what we are seeing in different settings as well, because you have multiple inappropriate use of antibiotic doses, right? And that's where if we're going to maybe have a prophylactic one-time dose, we could maybe potentially have an impact on resistance.
Thank you. Robert, go ahead.
All right, can you hear me now?
Yes.
Great. My name is Robert Rubiel. I'm a burn and trauma surgeon at Brigham Women's Hospital, and I serve as the director for the program in global surgery and social change. My question is, I think first to Dr. Ramos, but also Dr. Tita, I suspect you'll have thoughts to this. So maybe 6 months ago, I had the opportunity to be in Rwanda when the Rwanda Global Surgery Hub was presenting its results, or presenting the results of the Cheetah trial and the Falcon trial, which I agree are very pragmatic and really practice changing. Like, it's changed my practice here in Boston. Loved it. And so the question is one about pragmatically how to run the trial. So one of the strengths Rwanda had is that it's small and the surgical community is pretty tightly organized under the Rwanda Surgical Society. And so that allowed, those are facilitators for getting hospitals and local COIs engaged and then being able to enroll patients. Our discussion today has been the multinational piece of it, but I wonder at the national level, Dr. Ramos, Mexico is a very different geography and context and those things. And can you give us insights into what it was like? What are facilitators and barriers for running the national level part of this trial and getting teams engaged? And then Dr. Tita, you may have insights from the 7 different sites as well. Thank you.
Thank you, Dr. Riviello. I think that also it's a very good question, and you do understand the complexities that we may run into having to conduct this type of trials in different settings in different countries. So I totally agree. It comes to getting we have a model that it's a hub and spokes. So we do get a prior relationship with many hospitals across the country. We start working with them for different trials, and the hospitals that we understand that are more interested, that are more interested in working in collaborative research, those are the ones that we select first to be the spokes where we conduct these trials. However, this could also include some bias, because some of these places might have, different practices. Like one of the spokes that we were really happy to work with was one of the cancer institutes in Mexico, and this was a higher end hospital that by protocol they would change gloves at the end of every operation, and they would not adhere to such a practice to be included in a trial. So we had to exclude them. And so it varies. Mexico, like you said, it's a big country. So we try to find hospitals that were from different levels, that were from different places, that could deliver the trial. We're finishing a cohort study, a big cohort study that has included 55,000 patients just now on laparoscopic and open cholecystectomy across the world. And we found out, how this difference also come to happen in cohort studies, like the Indian hub, the hub in India. It's amazing the pace at which it can enroll trials. It's a big country, and they have a great influence among so many places in different areas with surgical associations. So it does help to involve the National Surgical Association in this, because it gives you more strength, and it does help to have a prior relationship with the spokes hospitals that you work and try to get involved in this. I hope this answers the question.
Yeah, I would agree with Dr. Sorry, go ahead.
No, just to say thank you, but please go ahead, Dr. Tita.
Go ahead.
I would agree with Dr. Ramos, and I think I've had similar experiences and a track record of having done this really, I think, is crucial in terms of all the procedures of enrolling, consenting, keeping them, follow up, and then quality of data, etc. I think would be great. But if for someone who is just starting up a program and looking at a new collaboration, I do think the leadership in the team is crucial. Having the right people who are appropriately trained is in research background would be great, and then having a great network to the clinical setup as well. Thank you.
I would also add one more thing, and I think it's key. Involving residents, involving students, registrars, it's also key, because they are eager to get their name on such trials that are published in high impact trial journals. So that's also key. And the authorship the collaborative authorship model, it's also very important for these trials to work, because it gets people involved, it gets people to be part of the system, part of the trial, of the study, and of the work.
I feel like those last 2 points are cross-cultural there, Dr. Ramos, getting residents involved and the authorship piece. Sakshan's hands up.
Yes.
He's in our room here, so.
Yeah, Sakshan.
Oh, I didn't want to create echoes. Hi, Dr. Ramos and Dr. Tiza. Thanks so much for such impressive talks and really such impressive studies. The scope is just amazing. I have a question for both of you about, I don't know which camera to use, the external generalizability. So these are already huge studies, but what other regions or countries do you think the findings are applicable for? And then for Dr. Ramos in particular, what other specialties do you think this is applicable for? And I ask that because the time and the money and the leadership required to conduct this kind of study is so immense. It might be hard for people who are doing, say, chest trauma or open orthopedic surgery or penetrating cranial trauma to repeat this kind of global study. So do you think people should just start adopting it in other specialties too, the findings? Thanks.
I'll go ahead first. I think that we don't have the evidence that it's applicable to other operations, but we do believe that it is applicable. And since it's a fairly pragmatic, cost-neutral intervention, it does make sense. It's a fairly simple thing to do. As a matter of fact, it was like we said, biologically plausible. It looked like it should work, and I think that changing gloves, either by double gloving or just changing the gloves at the end of the operation. I mean, double gloving, it's also a protection for the surgeon in some cases. So I think it does make sense. Like in orthopedic surgery, where you are in contact with sharp bones, double gloving makes sense even more. So I think it's applicable to a wide range of operations and specialties.
So thank you for that question, Dr. Ramos. I will just clarify. Double gloving, when we do that at the end of the procedure, before the wound is closed, they take off the top glove and have. So there is it's implied changing. But I'm curious to hear what you think about that. Should you really wear one and then change, or is double glove equivalent? In terms of generalizability, just to quickly answer that, we did subgroup analysis for the Asian region, there is, as you can see, a South American country involved here as well, and then the African regions. Clearly, no question about the African regions that it's absolutely beneficial in African countries. In the Asian countries and the Latin American country, the benefit is still there, even in spite of the broad antibiotic use. But obviously, there are smaller numbers, and the effect size is smaller. when you look at just sepsis, but when you look at any infection overall, it's also beneficial in those places. So I think in terms of policy, people have to look at their conditions and see, right, we have to speak to resistance, but I also think having a well-regulated prophylactic process might help resistance. And then as you roll this out, I would suggest doing evaluations, right? So you could be implementation evaluations to make sure that you're also getting the effects in your in the different settings. Thank you.
To answer to your question, Dr. Tita, the way that we conducted it was to get a new set of gloves that we would change at the end of the operation, and also have a fresh tray of instruments. That was how we conducted it. We do believe that until there are other context-specific data generated, I think this should be generalized to any type of operation in any type of hospital due to the pragmatic and simple intervention that this is. So that's it. Yeah.
Yeah. Thank you, Dr. Ramos.
Thank you both for those responses. And regarding policy, I think there's a question in the chat that speaks to that, but Professor Tita, you may have sort of indirectly answered this question, but I'll read it all the same. Thank you both for the amazing work. How do we shift from data to policy and then integration into practice, particularly in settings where healthcare providers are already frustrated with their current systems and optics changes might be challenging?
Yeah, thank you. And I think my response, started to speak to that, and some of that process is being engaged with, the World Health Organization. We've recently put together a conference that brought people working on azithromycin in the Gambia and Burkina Faso. There's an additional large study that will be coming out of Mali, soon, and we sort of mapped out, our findings, the important findings that we would like to see, and then also how we can do some systematic reviews, and especially individual patient data systematic reviews to get at some of the things that may not be specifically addressed by the individual studies. And then everyone is looking at resistance. And so just beginning to lay out that data and having conversations around them and answering, the questions that give people pause, I hope will lead to a situation where, and then also engaging with the different country partners, right? It's not always WHO, but if WHO obviously does it, that's terrific. I think it really gives it momentum. So engaging there and putting a committee together, which is in WHO's prerogative, I think will be one of the next steps with respect to azithromycin. But also countries should look at this and speak to how, the studies, speaks to their setting, and maybe, frankly, move towards policy, especially the African countries. Thank you.
Thank you very much for that wonderful response, but I'm afraid we're already short of time, so I'd like to close this particular session. By no means, if any of you still have more questions for our speaker, please reach out to the Research Pillar team and we'll forward you their questions. Taylor, could you share the map?
One moment.
Of the results of the Menti poll.
Taylor's now pulling your audio. While he's pulling it up, a public announcement or a PGC announcement. For those of you in the Longwood area, when we're done here, I encourage you to make the walk down for the NCDI symposium, which is going on at the research center down the street, whose name I always forget. We'll walk down there in a few minutes after we're done here. Here comes the poll. Yep.
Okay, we're totally out of time now. As we conclude, I'd like to extend my heartfelt gratitude to all the participants, and especially to our wonderful speakers who have contributed to the enriching discussions and insights shared throughout the session. Your engagement and valuable contributions have truly made this seminar a huge success. I would like to, use this opportunity again to remind every one of us of our upcoming and final seminar in this series, which, promises to be equally informative and thought-provoking. So please mark your calendars for April 11th, okay, same time as we delve deeper into implementation science in global surgery. Once again, thank you all for your active participation and, valuable inputs. And let's just look forward to our final seminar and continue our journey of learning and collaboration. Thank you very much and have a wonderful day ahead, everyone. Bye-bye.
Thank you all.
Thank you.
Bye-bye.